Namaste, I am Dr. Vishal Mukherjee.
Namaste, I am Dr. Sudip Haldar. I am surgical oncologist. Both of us surgical oncologists from Hope and Hill Cancer Hospital.
Namaste. I am Dr. Saptarshi Ghosh, consultant clinical oncologist from Hope and Hill Cancer Hospital, Jotia Kali More, Fulbari. So today we are here to discuss some important points on ovarian cancer, mainly on the management and new recent advances in ovarian cancer. Today is 8th of May, World Ovarian Cancer Day. So we would start with Dr. Vishal Mukherjee on some discussions on ovarian cancer.
So, most importantly, how a ovarian cancer presents, how we know that our patient is suffering from something which might lead us to an ovarian cancer. So we see patients normally present with an abdominal distension, a bloating. Patient had a feeling of there is a swelling in the abdomen. Patient is taking some meal, and usually the appetite, which was used to be good, there is a decrease in the appetite, and there is abdominal distension, there is lethargy, there is weight loss. So these are the common symptoms in which an ovarian cancer usually presents. And then the patient presents to us, and we start with investigation. We usually examine the patient, we examine the abdomen, we examine the gynecological part, then we advise few investigations. The most important of this is a CT scan. We advised a CT scan of the abdomen as well as a thorax, so that we can know how far the disease has spread, whether it has spread a single ovary or both ovary, whether it has spread the other organs, and doing that we classify whether the patient is in stage 1 or whether the patient has moved to stage 4.
So this staging is very important because it leads to our next investigation. If the patient presented with the early stage disease, then we don't routinely do the FNAC or biopsy, because we can manage it with the operation, and post-operative biopsy will lead to further management. If we are dealing with a stage 3 or a little bit of advanced disease that is spread to the peritoneum and other organs, then in some patient we need the initial biopsy to have some initial 3 cycles of chemotherapy, that is called the neoadjuvant chemotherapy, followed by assessment and surgery, and then again we are completing the neoadjuvant chemotherapy. So the operation is, in both of the cases, operations are same. It is a cytoreductive surgery. That means we have to resect out the disease, that is including the ovary, the uterus, the pelvic lymph nodes, glands, and omentum. So, and wherever we are suspicious there is some lesions in the abdomen, we have to take it out. So this is cytoreductive surgery, and accordingly where the disease spreads, we have to do the surgery to make it a macroscopic disease free when we are closing the abdomen. And then we need the biopsy, and then we refer the patient to the tumor board for discussion. Initially also there is a multidisciplinary tumor board, so how we can manage this patient, what will the combination of the treatment, chemotherapy first or surgery first, and then the chemotherapy portion will be discussed by Dr. Saptarshi Ghosh.
So what we can understand is today we are all three are here because they are the oncosurgical team of Hope and Hill, and I deal with the medical oncology part. So basically ovarian cancers are treated with mainly surgery and chemotherapy. There is some role of targeted therapy and PARP inhibitors recently. But these are the two main pillars of treatment in ovarian cancers, and hence we are practically doing a tumor board kind of discussion with you guys here. So about chemotherapy, as Dr. Sudip has already highlighted, that there we generally give 6 cycles of chemotherapy. Either we can give 6 cycles after surgery. So upfront surgery may be given for little early stage cancers, which can be taken out completely at the first go. First attempt, and sometimes in locally advanced cancers where there is a need to a little bit reduce the burden of the disease, then we give 3 cycles of chemotherapy first, which is called the neoadjuvant chemotherapy, and then go for the surgery. Again, the role of surgery is to take out the entire disease from the abdomen out, and then again 3 cycles of chemotherapy. Now, in the stage 3 and stage 4 resectable ovarian cancers, there is a role of a targeted therapy called bevacizumab, which is also given for 1 year along with the chemotherapy and even after that. And recently, there is an update. There are numerous updates on the role of PARP inhibitors. So, what are PARP inhibitors? PARP inhibitors are basically some oral tablets. These are being used in patients who are having a genetic predisposition to have ovarian cancers, they may be having BRCA mutation, or they may be having some homologous recombination deficiencies. So these are the patients whom we are advising the PARP inhibitors. So PARP inhibitors does reduce the risk of disease recurrence in ovarian cancer. So there are some new recent advances in surgery as well, like HIPEC and robotic surgery. So the surgical oncology team will highlight on that.
HIPEC is basically after the completion of the surgery, we give a heated chemotherapy so that even a microscopic disease which are present in the abdomen, the cells are killed after giving a HIPEC. And the role of HIPEC is established in carcinoma of ovary. But most important part, even before giving HIPEC, is to clear the abdomen disease-free macroscopically. Before clearing the macroscopic disease, there is no role of HIPEC. So CRS and HIPEC, cytoreductive surgery and HIPEC is the standard which is now coming up. But normally we see our patients presenting with stage 3, like little bit of advanced disease. But with these modern chemotherapy agents and these modern surgical techniques, the results of the treatments are very good, and we could see our patients doing well, coming to our follow-up and gaining their weight, gaining their appetite, and most importantly, gaining their confidence in life.
And for the robotic part, it is upcoming, and many a center having the robotic. It is very important to know that it is a new upcoming technology. So we can hear about it, but majority of the centers or the patients is not affording because of the high cost. But for oncological point of view, still we are not in a place to compare the open surgery and robotic surgery, particularly in case of an ovarian cancer, because the disease is entire abdomen. We have to go through the each compartment of the abdomen. So I think still we have a lack of data regarding the robotic surgery, but still it is upcoming. May in the future we may have the this technology, but now we are doing this all in open surgery.
So that's what was all on ovarian cancer today. So thank you.
Thank you.